Hello, I'm Dr. Jennifer Klemp. I'm a professor of medicine in the Division of Medical Oncology at the University of Kansas Cancer Center, and I'm also our director of cancer survivorship. And today I'm going to be talking with you about cancer survivorship. I think one of the most important pieces for us to discuss as we have this multidisciplinary audience today of providers and advanced practice providers, supportive care, patients, caregivers, all across the board is really right-sizing what we're talking about when we use the term cancer survivor. And whether we like this term or not, whether we want to call our programs survivorship programs, this was coined before many of us even embarked in survivorship. I opened our clinic in 2006, and that word was well seasoned prior to us opening our clinic. But the important part about the anchor is it gives us a population to really focus on, which is any patient from the time of diagnosis through the lifespan, and does include friends, family, caregivers, and really that extended network that helps support our patients through their cancer journey. Another important point is we have to think about patients living with and through their cancer. So the cancer survivor could be someone who had early stage disease, they're on long-term endocrine therapy, and they will have extended therapy for 5, 10 plus years. It could be a patient who was diagnosed with metastatic disease and will continue to be undergoing treatment for the rest of their lifespan. It could be a patient who also has a genetic mutation. We have risks for second primaries. So we really need to think about the different phases of cancer survivors and how our program and how the survivorship care that we deliver affects both patients living with and through their cancer. The silver tsunami is a effect that's been happening, as you can see, over the past, really 20, 30 years, where we have a significant growth in the number of cancer survivors living with and through their disease, but we also have a disproportionate number of patients over 65. 2/3 are over 65, which also means that patients are more complex. They have multiple comorbid or other health issues that impact both their risk at the time of diagnosis and then ongoing. And we know that patients who are at the top of the age bracket and the lowest are at the highest risk. So our youngest patients and our oldest patients who bookend the silver tsunami are the highest risk target audience. The middle buckets, we need to use some tools to refine the risk. And that's really what I want to focus on today, is how do we use risk stratification in survivorship to help us all along the journey understand the needs, the resources, and the interventions appropriate for our cancer survivors. So this is a slide that defines our program at the University of Kansas Cancer Center. We developed this figure in 2006, and it's helped us anchor what that should look like from a programmatic standpoint as we develop those tools and resources, and then for our survivors to really see what that journey should look like and hopefully does look like. So if survivorship begins at the time of diagnosis, we absolutely need navigation to help guide the patient along this complex journey. We need biomarker testing and genetic testing and different ways to understand what types of treatment would be most effective, what the risk for reoccurrence is, and also potentially germline testing to know, was this something inherited? And then also what would that look like as an impact for the patient's family and extended family. We know we need to think about that treatment plan and really think about using shared decision-making, what the goals of treatment would be, what the goals of the patient are. And these roundabouts are very purposeful. So some patients enter a treatment phase of care and will stay in that phase. Some will leave and come back. Some leave and a few years come back. And a lot of patients go on to longer-term survivorship or extended survivorship into continuity. So we need to be able to think about, well, a patient who's newly diagnosed, a patient who's in treatment, or a patient who's 5 years out, there's common denominators that we need to think about in providing them with survivorship care. And that includes genetics, lifestyle, cardio-oncology, sexual health. So the important part about using an anchor such as this figure is it really does help you understand what's necessary along the journey. When do we need these types of tools and resources? And how do we also engage other supportive services, other experts, and the specialists that we would depend on, as well as the person who's going along this journey, which is the survivor and their caregivers. So using risk stratification means we need to understand, what these treatments do, how they impact potential late and long-term effects, and how potentially overlaying each other adds complexity to understanding the real impact. But at the end of the day, we need to understand what is the greatest risk actually for the patient sitting in front of us. And one example that I would use in extended survivors is both breast and prostate cancer survivors over 65 with early stage disease. They have a greater or equal to chance of dying of cardiovascular disease than their cancer. So are we doing our job at making sure that we are focused on what really is important in regards to our patients' risks, how we educate them and mitigate them, and do we have a team in place to really help understand what those risks are? So taking those contributing factors and putting them into a risk stratification model means we also need to understand what are things likely to happen during treatment, or what we would call long-term effects, things that would happen as a course of treatment and maybe persist, like fatigue, loss of fertility, cognitive impairment, or what's more likely to potentially impact our patients and survivors long-term, cardiac risk, long-term issues dealing with our bones or our lungs. So how do we really put that into perspective? So that means we need to have a whole patient approach. And this is pretty complex. It means we need to understand how treatments affect our patients, how the ever-changing landscape of treatment opportunities and combinations thereof can impact head to toe, our brains, our bones, our heart, our sexual health, our really every kind of system that needs to work in a nice symbiotic fashion doesn't always work that way because of comorbid conditions or because of the diagnosis and treatment. So we have to have a baseline understanding. We need our survivors and our patients to share what their issues are, either through a patient-reported outcome, like a tool or a survey, or they need to be part of the process to share when there's something that's happening that is not their baseline. Something new has happened. Something has sort of been accelerated or exacerbated. We also need to have good educational tools that are built to the educational style of our patients. Maybe it's visual, maybe it's auditory, maybe it's watching a 2-minute video over something like drain care or how do you combat fatigue. And then we need to have an ongoing risk assessment. An ongoing risk assessment, and I'll show you this and I'll flip back, is essential, because if we assess something at baseline and then we never go back to that, then we don't really know how our tools are working or our interventions working. So we have to go back and think about, well, where are we intersecting with that survivor? How do we want to go ahead and use our tools to assess that risk? And how do we put them in a risk bucket initially based on the diagnosis and treatment? And this isn't perfect. So, it's kind of meant to sort of put our current therapies into buckets to help prioritize what those risk levels would be. But this shows you that we don't have one size fits all, and the different levels of care and therapy would lend to which bucket a patient falls into. The next piece is, how do all these other aspects of survivorship also impact our patient? So yes, they may have early stage disease, but they have financial toxicity that is significantly impairing their ability to be adherent to their treatment plan. So the important part about the NCCN guidelines, although a little overwhelming to look at and think about doing in a 20 to 30-minute visit, it means we need to be addressing these issues along the way, so everything isn't done at one time point. We really need to understand those risks for our patients and how we can engage them and help really work once again in that bidirectional fashion to address what could be a greater issue for the patient, dealing with cognitive impairment and being able to maintain employment, to keep insurance, preventive health issues. Do we know how to continue to help our patients get access to supporting their comorbid conditions? So the important part is understanding what these pieces are, putting that risk stratification into practice, low, moderate, high, based on maybe high risk for recurrence, but low risk for some of the other supportive care needs, or low risk of recurrence, but high risk of social needs. So how do we put those pieces into practice? And so assessing that risk, doing that ongoing needs assessment and figuring out which the greatest risks are for the survivor is essential. And then you need to take inventory of your toolbox. What's in my toolbox? What needs to be sharpened? What tools are missing? And so how do we help navigate a patient based on that risk assessment into the best opportunities for managing late and long-term effects? Do we want to use a care plan for documentation? Do we just need an order set or a to-do list? How do we engage and educate both patients and providers on our care team as well as collaborators? And then how are we using technology? That would be both our health record, it would be video tools, whatever that technology is, it has to be optimized for scalability and really accessibility of survivorship care. So lots of people say this is important. It's obviously important because we have so many more patients living with and through their disease. And we really need to put this into a construct that works clinically. And so if we put this as a separate thing out here, it never gets integrated into care. So survivorship care and all the pieces that go with that really need to be organized and implemented into our standard delivery of oncology care. And then as patients go along that journey, we do need ways to reallocate where they maybe see their providers. So we do have advanced practice provider clinics, for instance, for long-term continuity of care. We work with our primary care physicians so that health maintenance and other factors can be managed. So that piece is essential at being able to deliver high quality care based on the patient's needs. And that means we need to role delineate. We need everyone on the team to understand what their role is, understand what their scope is, and really fill that role. And we need to empower them. It's kind of led by the cancer care team, sort of, the coach of the team. We also know that the survivor is really a central player, but sometimes has the least amount of tools or skills because we don't train them to really fill that role. So how do we empower them? How do we make sure that those tools and resources are there? And then how do we use and educate our other primary care and specialists along the way? So we do need a village, but the village can get really complex, and it doesn't mean every patient needs to see or have access to each of these types of disciplines. But it does mean that we as healthcare professionals need to have a program that allows us to connect our patients with whatever specialist or resource is out there. So I think the village has to be built, and you have to have those roles delineated. And then the Office of Cancer Survivorship has recently added this figure to their website, which shows you take that village, you have the group of specialists and primary care and all sorts of supportive care individuals. And now here are the constructs that we really need to focus on based on special populations and health disparities, health maintenance, psychosocial, physical, all those different pieces that we need to put into practice. These are the services that are delivered in our village. And so it's really important to think about it from that vantage point. There's a lot of barriers we know in getting that continuity of care from the cancer care team to the primary care to the patient. So we developed some cross-cutting themes that really went along, whatever discipline someone was in. So I think that if you can just sort of use these tools to help you as you're conceptualizing program development, or if you're a survivor and you're watching this today, what's your role in making sure you communicate and you are that conduit between your primary care or specialist and your cancer care team. So everyone needs to fill this role and address these barriers based on that provider communication, the knowledge gaps that exist. How do we actually help access these resources? And what are the limitations in our organizational structure? And how do we work together to really develop that? So here's the to-do list for empowering the survivor and engaging in that day-to-day and being part of appointments and cancer screenings and adherence, as well as all the lifestyle and health maintenance factors that are vital for a healthy survivor. There's a lot of key challenges, so I wanted to put this here. You'll have access to these slides. So from your stakeholder standpoint, you can kind of see what your roles and responsibilities are, what the key challenges are. Maybe it's optimization, maybe it's difficulty, working between your primary care and your specialists. But these are the challenges, and there's some proposed solutions. So the important part is this growing population isn't getting smaller. We need to embrace this role delineation and empower our survivors and really work together to deliver high quality survivorship care. So thank you for your time today.